time. So good afternoon, everyone. I'm Donna Rice, the Chief Operations Officer for Diabetes Sisters, and we are thrilled to have you with us. For those who don't know Diabetes Sisters, we're a community and we're dedicated to empowering women living with diabetes throughout their life with education and advocacy. So thank you so much for joining us. Our webinars are really crafted to inform, enlighten, and provide essential information that can make a good difference in your life. So throughout today's presentation, please feel free to submit your questions in the Q&A feature, and we'll certainly address them at the end of the talk. Today's Expert Series webinar is brought to you by Eli Lilly, and we're honored to introduce our esteemed speaker, Dr. Courtney Younglove. Dr. Younglove is a dual board-certified physician in obesity medicine and obstetrics and gynecology. She is one of the few clinicians in the U.S. to have earned her OMA Fellowship, which is Obesity Medicine Association Fellowship in Obesity Medicine, an accolade that recognizes her dedication and expertise in treating obesity and related conditions. Dr. Younglove is the founder and medical director of the Heartland Weight Loss with clinics in Overland Park and Lawrence, Kansas. Her passion lies in making evidence-based treatments accessible to all people battling obesity, aiming to improve overall health and reduce healthcare costs. Please join me in welcoming Dr. Courtney Younglove.
Thank you, Donna. Okay. So a couple objectives we have here. You can look through these later, but I really just want to help people understand the basis of obesity medicine, the relationship between metabolic health, obesity, diabetes, and then how we approach treatment of these things together as a holistic process rather than in various silos. And then really take that knowledge and build upon it to say, how do we make a solid treatment foundation when embarking on that process? So a couple just definitions at the beginning. Cardiovascular disease is the #1 cause of death for women. We think about this so often as a man's disease, and it is by far the primary driver of death for women. And it really stems from a lot of things. And we discuss that in terms of cardiometabolic health. So we start talking about how do we prevent cardiovascular disease? What gets us there? We talk about the things that affect cardiometabolic health, which is a combination of things that leads to cardiovascular disease. And cardiovascular disease is more than just heart attacks. It's diseases of the cardiovascular system, which is the blood vessels that leave the heart, go through the body, and come back to the heart. So the vascular system as well. So that encompasses myocardial infarction, heart attacks, but also strokes, which are another big leading cause of death for women. And what's overwhelmingly frightening is that as of 2018, only 6.8% of the US population, the adult population, has good cardiometabolic health. So this is a huge problem. And the way we define cardiometabolic health, when we say, yes, this is someone with good cardiometabolic health, it's having all 5 of these checkboxes. So having a body mass index and waist circumference in the ideal range. So having low levels of visceral fat in the abdomen is really what that comes down to, measured by waist circumference. It's having normal blood sugars without requiring medications to get us there. It's having normal cholesterol levels without requiring medications to get us there. Normal blood pressure, so the blood vessels, without needing medication to get us there. And then no previous evidence of cardiovascular disease. That's really what makes up cardiometabolic health. And diabetes itself right there is in that realm. And we do know that people with diabetes have a much higher risk of cardiovascular disease than the general population. It is a risk factor for cardiovascular disease. And the thing I want to impress on everyone, this is a visual that I borrowed from a UK company called Health Results, but it's a beautiful visual, is that cardiovascular disease, diabetes, obesity, all of these things we talk about are outcomes. They are outcomes of a bigger problem. So there are branches on the tree that stem from an underlying problem. And that's, I think, what we've missed in the US healthcare system so much, is trying to treat these silos without looking at the bigger picture, is that these diseases are outcomes of a bigger problem, the bigger problem being insulin resistance. And if you take that problem and say, well, what causes insulin resistance? So you move down the level or up the stream, however you want to put it, this insulin resistance is a problem that is built upon other things that are lifestyle things. So stress, food, movement, sleep, these kinds of things, when not put together well, create insulin resistance. Insulin resistance creates these downstream problems, or these branches of the tree. So this is a really important visual. And this is a zoom in on it. It's hard to see it on a zoomed out thing, but looking at these different things that we suffer from, and there's more of them, this is just the visual that I've got from this company that's beautiful, is that these are outcomes. So we need to think about it that way. When we start thinking about it that way, it's a lot easier to make progress in treating it. We do focus heavily on diabetes and obesity. I mean, you'll hear that, and this is a diabetes group, so obviously that's probably something you've heard before. And obesity is a big problem in the US. So 42% of American adults are suffering from obesity. Another 30 to 31% are suffering from pre-obesity, we call overweight. And we know that there is a correlation. We know there is a significant overlap. It is not a causation. We'll talk about that in a second. But obesity and diabetes and pre-obesity and diabetes overlay each other pretty well. I mean, people living with obesity are 6 times more likely than people without to develop type 2 diabetes. So there's clearly a relationship, but I would argue very strongly that it's not causation. And there are a lot of people in this world that have diabetes that don't have obesity. So that's something we have to kind of dispel some myths. Unfortunately, a lot of people think about it this way. They think about obesity causing diabetes, obesity causing high blood pressure, obesity causing certain cancers, or sleep apnea, or PCOS, or all of these other branches of the tree that we just showed. And it's not the truth. So really, we need to look at it this way, as this cardiometabolic disease drives obesity. It also drives these other things, but it's why we can have people that have diabetes that don't have obesity, or people that can have high blood pressure without having obesity. So really change that narrative is really important in the world of obesity medicine, in the world of cardiometabolic health. So realizing, looking at it this way really helps put things in perspective. So cardiometabolic dysfunction causes obesity in a lot of people, not all of them though. So some people get diabetes and obesity, but some people just get diabetes without obesity. And some people get obesity and fatty liver, but not diabetes. And some people get obesity and heart disease, but not hypertension. So there's various manifestations of this problem that we see. And some people get all of them. I mean, this is where there is so much variability in the way our organ systems manifest cardiometabolic dysfunction. So obesity is probably the most prevalent manifestation of cardiometabolic dysfunction, but again, it's not the only one. And one of the ways that I describe this to people is, I have this little ranch house in the country it's got short roof. It's an old house. And so you could line up 10 people on my roof and have them jump onto the grass below. And most of us are going to get a problem when we do that. My 18-year-old young son might be able to jump off that roof and land okay. I'm going to probably break an ankle because I have weak ankles. I might hurt my back. I might be okay from my arm standpoint because my ankles might take the brunt of that, but my neighbor might break an arm. Somebody might break their neck. Somebody might hurt their knees. It depends on how we land, how we're genetically predisposed to land, how we jump, how soft the ground is, what's underneath us when we land. There's so much variability. Most of us are probably going to get ill effects from it, but not everybody's going to get the same thing. So kind of thinking about it in that way helps describe why some people are going to get more than others. And then realizing there is a circular pattern of these things. So getting one manifestation of cardiometabolic dysfunction can often force other manifestations, which then forces other manifestations. And it really can become a spiral effect that's very difficult to interrupt. And so bigger questions that we need to be asking as patients, as providers, as people that live in a health system is, why do we have such a high incidence of cardiometabolic dysfunction nowadays? Why is there such a link between cardiometabolic dysfunction and weight gain? And appropriate to this audience here is, why is there such a strong link between diabetes and excess weight? They're all overlapping issues. And the big one comes down to insulin. I'm going to move my screen over here. You can see that. Let me go back here a minute. So insulin is a hormone that in a world of diabetes, everybody's probably fairly familiar with. This is what it looks like if you actually put it into an electron microscope and make it all pretty. But insulin is a hormone that drives this cardiometabolic dysfunction. And it makes sense when you look at it at what does insulin do? So when insulin is secreted, the body is driven to store fuel, to lower glucose in the bloodstream, because we know having too much glucose in the bloodstream is not good for us. So insulin's job is to get it out of the bloodstream. And where does it store it? It stores it in fat cells. And then insulin's job is to go away so that when the body needs more fuel, it pulls it back out of the fat cells into the circulation so the body can use it. So insulin is the driver of not only blood glucose, but of fuel partitioning in the body. And what we do know is that when insulin goes up, it is a signal to the body that we have excess fuel, we don't need more, which then makes leptin go down. And so leptin is this driver of food intake. And this is a system that is designed to really help us balance our blood glucose levels throughout the day. And it's the primary feedback loop for hunger and satiety or fullness, which is great until it doesn't work right anymore. And when you get insulin resistance, it means that feedback loop is no longer working well anymore, that the body's not listening to insulin anymore. So the body starts cranking out more insulin and it quits listening. And it's way too deep to get into here in the 30-minute webinar, but the biochemistry behind insulin resistance is a driver of dysfunctional signaling down the road. And what's relative here is what causes insulin resistance. Why are we getting this thing that then drives these other things? There is a genetic predisposition to insulin resistance. Now, most of us are genetically predisposed to it anymore. We've self-selected that out because it's a survival tactic in times of food scarcity. Nutrition drives insulin resistance phenomenally. That's what probably the biggest driver we have today. Exercise or lack thereof drives insulin resistance by upregulating insulin receptors on muscles and other tissues. Medications can drive insulin resistance. Our gut microbiome, we're starting to learn, has a huge role in insulin resistance. Stress, so chronic stress, acute stress also affects this, but chronic stress drives the production of cortisol, which drives insulin resistance. Lack of sleep drives insulin resistance. There are toxins, what we're starting to call obesogens. So endocrine disrupting chemicals, a lot of times are now being classified as obesogens. They drive insulin resistance. They drive fat cell growth. There's a lot of things that drive this. Thankfully, most of these are under our control. We can't change our genetics, but we can change our epigenetics, which is the genetic expression of our genes. So most of these are under our control, but they exist independent of a lot of what we do. And some of the problem is we keep looking at weight loss, which is what we want to talk about today, independent of these other things. And we really shouldn't. And this is the old-fashioned conventional way of looking at weight loss, is that it's this thing independent of these other things. And that the solution to weight loss is really to just decrease the fuel intake so that we don't have that anymore, or increase our fuel expenditure. So this calories in hypothesis that really needs to come off this planet as a driver of obesity, but we're stuck with it. It exists a lot, but really stopping this old-fashioned notion of looking at calories in, calories out to affect obesity all by itself. That we need to look at the driver of obesity and the driver of these other things and really work upstream. So that's what I do in my clinic. It's what my team does in my clinic. It's what I speak about all the time. It's what a lot of us in this world of metabolic health are working on, is moving to the roots of the tree, to the branches, to the trunk of the tree, which then affects the branches of the tree and the manifestations of the cardiometabolic disease. So I think that's what I really want to talk about today is how are we treating these things? What are our treatment options? How do we approach treatment? We think about treatment options in the world of obesity medicine and metabolic health management in layers, that we have different layers of treatment. And if you just look at them in a silo of what kind of weight loss do they cause, that's over here on the right. Now it's again nuanced. Most of the data on here has been developed in the calories in, calories out model because it's so prevalent everywhere. But realizing that lifestyle interventions by themselves can usually cause some weight loss. Then you add in some prescriptive nutritional interventions, you can make that much more effective. You layer in some pharmacotherapy, and then you can layer in bariatric surgery. And as you intensify the treatment, the results tend to intensify as well. So let's talk about lifestyle interventions. So lifestyle interventions involve treating obesity using the pillars of obesity treatment. So lifestyle is more than motivating people to eat less, which unfortunately is the way it tends to condense down in a lot of commercial places. But really using the lifestyle interventions of all four pillars of really that intensive nutritional intervention, behavior modification, which involves a lot of psychology, activity modification, and then the medical pillar there. And then adding in a prescriptive nutritional intervention. And that is different than a lifestyle intervention to a degree because a prescriptive nutritional intervention involves lowering insulin. And that's something we do in that metabolic space, that obesity medicine space, is say, okay, rather than just saying eat less or eat differently or control your portion intake, how do we eat to lower insulin? That is a huge bucket that we have to address, but doing that really starts to work on the trunk of that tree, which is really, really important in the world of metabolic health improvement. And then layer in some pharmacotherapy, which is wonderful. We use that quite a bit. And then bariatric surgery, I'm not going to discuss here. That's actually a huge player in the world, especially for people that have grade 2, grade 3 obesity. Sometimes that is a layer that absolutely needs to be done in order to really move the needle on long-term health. But we want to talk about some of the pharmacotherapy treatments, because that's the world that we live in right now with obesity medicine, is really what do we use and how do we use them and how do we use them right? So phentermine is an old anorectic medication that's been around for 50 years. It has some cousins that we use in the obesity medicine world. There's medications called phendimetrazine. There's medication called diethopropion. These are medications that we use that are under the category of anorectics or stimulants or appetite suppressants. You can hear them called all sorts of things. We use these quite a bit in medicine. They're really, really cheap, which makes them lovely for a lot of people who don't have unlimited funds, which is most people in the world. They're very accessible. These medications work to decrease our appetite. They might change our resting energy expenditure. It's very debatable. The studies on these medications are really, really old. And because they're not under patent, it's really hard to study them today without a great deal of funding, which you're not going to get because it's complicated. But so most of what we have to use is anecdotal. It has to do with newer studies and looking backwards, but we do use them. And in my clinic, we use them a lot. They're very, very cheap. And they're very, very effective when used in the right way. Do they have side effects? Yes. All of our anti-obesity medications have side effects. I wish we could come up with medications that don't have side effects. They're usually pretty minor when we use them in the right context and the right people. The big ones that we see are dry mouth, constipation, and trouble sleeping. I mean, those are your three. They're usually fairly fixable using the knowledge of why they occur and really adapting the therapy to work on those things. And that's what a good obesity medicine provider is going to do. There's a lot of people that can't use these medications. So obviously we don't use any anti-obesity medications in someone that is pregnant or nursing. Those are not things you want to do. We can't use these in people with a history of severe cardiovascular disease, like having had a stroke or some arrhythmias, uncontrolled high blood pressure. We don't use these in people with an agitated state, people with active hyperthyroidism, other agitated states like mania. There's a warning not to use it in somebody with a history of drug abuse. We actually have no reports of drug abuse of these drugs ever. Nobody comes to the ER drug seeking these. There's no tolerance to these medications. So that it is something on the contraindications profile, but we're not so worried about that. They are related to amphetamines, but less so than Ritalin and Adderall, drugs that people take very freely and small children take. So less scary than a lot of people think they are. Neat weight loss, if you look at the average weight loss in the studies for these drugs, is about 7 to 10% versus placebo as that lifestyle intervention. So they're good drugs. They are. They're only FDA approved for short-term use, but we have lots and lots of data about long-term use on them. So don't dismiss these drugs in a world of obesity medicine because they do work. Orlistat is another anti-obesity medication. I will tell you just off the record here, I never use this medication. The risk-benefit ratio to me doesn't argue it. The makers of that would probably, come after me, but the mean weight loss compared to placebo is very minimal. The side effects are pretty awful. Like nobody really wants to have fecal incontinence. I don't know of any working human that really can live with that side effect. So there are a few people that it does work for, and it has in the past, but it's not one that we use very much at all. Contrave is another anti-obesity medication that's been around for a long time. It's a combination of two old generic medications put together that really have synergy to help treat obesity. And it's a great drug for a lot of people. By themselves, these medications don't have effects on weight, but synergistically, they really can for the right population. It's kind of nuanced, and again, something that often really needs an obesity medicine provider to decide who is it going to work for and who isn't, and how do we figure that out, which is well beyond the scope of this talk today. Yes, there's adverse effects, as there is for everything. The typical adverse effects for Contrave are nausea, constipation, and sometimes headache. Contraindications, just like there is with every drug, is uncontrolled high blood pressure and glaucoma, similar to other medications. Again, agitated states like mania, bipolar mood disorder. This has a contraindication on the labeling saying nobody with history of anorexia or bulimia. That was really added after really looking at who should be taking anti-obesity medications in general. I would say that probably should be on all of them, is that really needs to be under a lot of close supervision for all medications, but it's on their label. We cannot use this medication in patients with a seizure disorder. Wellbutrin, bupropion, this old drug, lowers the seizure threshold, which really means nothing to you and I that don't have a seizure disorder, but for people that do is a concern. And then naltrexone, which is a piece of this medication, blocks the opioid receptors. So people that take opioids to treat chronic pain disorders, we don't want to block those receptors. So a few more contraindications than the last one, but again, not affecting a huge portion of the population. The mean weight loss on this is about 7%. I will tell you, in an obesity medicine practice, when we're using it at a very targeted population, that goes way up. But if you just gave it to everyone without a lot of intervention and a lot of selection, you're going to get about 5% weight loss overall over placebo. So nuances. It does tend to work very well with emotional eating. With the reward pathway. Again, that's the obesity medicine nuancing there. And it's fairly cheap. I mean, it's $100 a month through a specialty pharmacy. Most obesity medicine providers are going to go right to that specialty pharmacy if we don't have insurance coverage for it, but $99 a month, and that's for the maximum dose. And so most anti-obesity medications, when they're being used by someone in the obesity field, are going to titrate much more slowly. So you can often extend that to a couple of months for a lot of patients. So a very reasonably cost-effective medication for a lot of people. Qsymia is another anti-obesity medication that's FDA approved to treat obesity. It's got phentermine in it, what we just talked about, and then you add topiramate to it. Topiramate is an old drug that we use to treat migraine headaches, but it tends to augment the effects of phentermine and allow us to use a lower dose of phentermine. And then this puts it into an extended release tablet, which makes it a great drug because it's a once-a-day dosing. You can use lower doses with minimal side effects. So kind of thinking about how do you make it easier and safer and less drug heavy in a human body, you make it more extended release. So yes, there are side effects to this one. Same side effects of phentermine, but again, since you get to use a lower dose, the effects tend to be minimal. That dry mouth, trouble sleeping, and constipation, you tend to minimize those side effects. Topiramate by itself has some side effects. You can get some numbing of the fingers and around the mouth. It goes away when you stop it, but some people get that with topiramate. Again, at a low dose, this is pretty minimal. when you use it within the Qsymia medication, but it can still be there. And contraindications. I mean, the big one with this medication is, again, pregnancy and nursing, but women trying to get pregnant. So topiramate, that migraine headache medication, can cause birth defects if somebody gets pregnant taking it. So we would never use this in someone who's not using birth control, who's trying to get pregnant, who might accidentally become pregnant, that kind of thing. That tends to be our big limiting factor in obesity medicine. And weight loss with this drug is pretty darn good. I mean, if you put everybody on it, you're going to get 9 to 10% versus the 2% placebo that responds to that lifestyle intervention. So pretty darn good effects there. And again, pretty cheap. So this is a fairly cheap medication through a specialty pharmacy. It's about $98 a month. Okay, that's fairly reasonable in the world of cost. And I will tell you, one of the things that we in obesity medicine have used topiramate for a long time, even before Qsymia came on the market, is topiramate can alter the taste of food, especially soda. It makes people not want to drink soda or lemonade or sports drinks or those kinds of things. For whatever reason, nobody can ever figure out, it's a good drug for that. So we use it quite a bit, even by itself, for just altering that taste of food. And then we get into these GLP-1s, which is what everyone's talking about. This was the first GLP-1, Saxenda, which was a rebranding of Victoza, which is a diabetes drug that has been on the market for, I think, almost 20 years. It's been out there for a long time. I'm going to kind of lump these GLP-1s together a little bit because they do work so similarly that I don't want to repeat myself and waste your time, because I know you'll have questions about these. But these GLP-1 medications, Saxenda included, work on insulin secretion, glucagon secretion. They also work on delaying gastric emptying, so food stays in the stomach longer. All of these mechanisms of action work to decrease hunger signals. GLP-1 is a hormone that we naturally make in response to food intake that tells us to stop eating. This kind of hijacks that mechanism and keeps it going so you feel full longer, not necessarily because the food's in your stomach longer, but because those hormones are sticking around longer. It also works on insulin sensitivity, glucose uptake. I mean, it's a complicated molecule, but it really works physically on that sensation of hunger. And then it works in the brain too to decrease appetite. So it's a dual mechanism there. Adverse effects of Saxenda is similar to the other one. So we'll kind of talk about that briefly. By working on that GI system, we see nausea, we see constipation, we see diarrhea, we see vomiting, we see those GI side effects because those GI hormones are being affected. And then a few other little things that we'll see about headache and that kind of thing. Contraindications, obviously pregnant. Anybody trying to get pregnant, we don't want this drug in the system. It lasts in the system longer. So we don't want people getting pregnant who are taking it. We don't know much about how that affects the fetus. And then you'll hear about this all the time, is this family history of medullary thyroid carcinoma or multiple endocrine neoplasia type 2. These are very rare conditions in the family, but we obviously don't want somebody taking these medications that has this just because of animal studies. And so those are your big contraindications. There's some other ones that are softer. They're not hard and fast, but we don't tend to use this medication in people that already have a history of gastroparesis, which is slow emptying of the stomach. We obviously don't want to worsen that condition. Excuse me. History of pancreatitis. We're very, very cautious in that. So you can get some pancreatitis from these medications. Again, a rare side effect, but somebody who already has a history of pancreatitis, we're very cautious in using these medications. Weight loss on these various GLP-1s varies. So this is the first one. Mean weight loss wasn't that great, but it's still good. And it's a daily injection. So that was the first round of GLP-1s FDA approved to treat obesity. Then we got Wegovy. And so Wegovy is semaglutide, which was Ozempic, which is a GLP-1 used to treat diabetes. It was rebranded and FDA approved as Wegovy, but Ozempic has been around for a long time, kind of same mechanism of action. It's a longer acting molecule, so it only has to be delivered once a day or once a week, which is a huge improvement in tolerability. It's just a newer and fancier version of Saxenda, or it works better with less side effects and less frequency of administration. So everyone's heard about Ozempic nowadays, I'm sure. Wegovy is the actual one that we use to treat obesity. Same contraindications, same mechanism of action, same side effects, but mean weight loss is much higher. So mean weight loss of semaglutide in all of those forms is about 15% in studies versus 2% in placebo. So much more effective. And it's a weekly injection. Downside is it's very, very expensive, as I'm sure you know by now. And then kind of the next level of medications in this category is Zepbound, which is tirzepatide or Mounjaro. And this is actually a dual agonist. So it works on GLP-1 and GIP. So dual agonist effect, which is phenomenal. It makes the effectiveness more, it makes the side effects less. I mean, we're really getting more and more evolution in this category of medications of how do we get the effect without the side effects? How do we get the effect with less trauma to the body, that kind of thing. And so this is the next level, tirzepatide. And again, once a week. And if you look at mean weight loss in this drug, it's 21% versus a 3% placebo effect. So again, getting better with less side effects, same contraindications. There's actually a contraindication in this one of, we certainly don't want to give it to somebody who's not preventing pregnancy. We talked about that before. It also has a side effect of lowering the effectiveness of oral contraceptive pills for the first month you initiate it. And then for every month you increase the dose. So we're very cautious of this in women on birth control pills because we don't want you to get pregnant. We don't want to lower the effectiveness of your pregnancy prevention tool if it is an oral contraceptive pill. So there's a little bit more nuancing there of who should and should not take it. Things that you deal with when you see an obesity medicine provider, that's kind of common sense to us, but we do need to be careful of this medication when we're getting it from random places. But it's a good drug. So looking at those different treatment options, layering them on top of each other is very, very helpful. And then layering on bariatric surgery, which works synergistically with medications a lot of times in conditions when that's an appropriate treatment option. It's the most effective thing we have. So looking at it that way, that's the way we think about these interventions in obesity medicine. And then what are you trying to accomplish with your interventions? And so this is really where it ties into that insulin resistance tree thing, is that there's two ways that we need to look at how these interventions work. And so all of these interventions, the lifestyle intervention, the nutritional intervention, the medication interventions, there's two things that they do. And this is not scientific. This is just the way I look at it when I'm approaching treatment to a patient is we need to work on the physical hunger that drives food intake. And then what we call food noise. We've called this for years and years and years, is that there's something called food noise. It's pretty easy to fix physical hunger. I mean, with or without medication intervention, dealing with physical hunger is pretty easy to fix by uploading healthy protein intake, healthy fat intake, and high fiber. Those things all turn on GLP-1. They turn on cholecystokinin. They turn on hormones that tell the body, I don't need to eat anymore from a physical standpoint, which then leaves us with noise, which to me as an obesity medicine provider, this is a much bigger issue than physical hunger. If we don't address physical hunger, that's a problem. I usually describe it to my patients as we're fighting two enemies. And if you try to fight the hunger enemy and the food noise enemy at the same time with two different swords, it's almost impossible. So we fix the physical hunger piece and then put both hands on the sword for the food noise, because it's really, really hard. And there's lots of things that contribute to the noise. There's external noise, there's time, there's access, there's confusion, there's habits, there's systems, there's internal noise, which I think is the most loud noise that most of us have. It's all the things in our brain that tell us, I don't want to do this, I want to do this, the push, the pull, the shame, the reward, that kind of thing. And if we use these medications in the context of a full treatment algorithm where we use them to calm the noise, it allows us the space to make the lifestyle changes. So realizing, how do we use these medications? What do we do here? The medications don't cause weight loss, the lifestyle changes do. And if we use them well, then we can actually create the noise fixes. So use the AOMs, use the medications to attack the right drivers. You guys can look at these slides later. I want to give you plenty of time for Q&A. But using them to quiet the noise, then attacking the lifestyle interventions is really the key behind it. And so how do we decide to do that? There are things that we decide to do. In obesity medicine, we have to take into consideration all the 5 C's of how do we choose the right intervention for the right person. And it has to do with cost. It has to do with all those contraindications and indications. It has to do with, do we use the right therapy for the right diseases? And then what are the cues, what we call in precision medicine, using the right drivers? And then level setting expectations of what are you going to get from each of these interventions. Treating the cause is really, really important. And then again, looking at it as a pyramid. And so the thing that a lot of us are doing nowadays is saying, I want to put all my chips in this pharmacotherapy bucket, which really doesn't help well. So when we do this, we often see this, and this is not what we want to see in obesity medicine. So hopefully that was fast enough to leave time for Q&A. I can't see what time it is. Donna, hopefully I have enough time and everybody's still here.
Yeah, I'm coming back. Hang on.
Okay.
Need to get my camera back on, and here we go. Okay. That
So
was
much to
that
say,
was
but hopefully it
amazing.
puts it in perspective of this is not just a discussion about medications. It's using them the right way. Yeah.
Yeah. And I love the big picture thinking. It's not just obesity, it's not just
Yeah, it's
hypertension,
not.
it's not just diabetes, and it's putting
Right.
the whole picture together. So thank you. And it was
Right.
so much information. It was great. We have a few minutes left. So I see that
Okay,
there's
good.
a couple of questions that have come through, and I definitely want to answer those questions. So hang on. The first question is coming from JD. And it says sugar addiction, the cravings. Is there perhaps something driving that? And are there things we can do to help decrease the addictions or tips for managing the cravings? I have tried a sugar fast for 40 days. Health improved, but the cravings never went away. It's a battle.
It is a battle. Good Lord. It's probably the biggest battle we have. I mean, if you look at the physiology of why do we have cravings and what's happening, it's fascinating. And most of the time it has to do with our insulin being up. So the body has this insulin up, but it can't access the glucose that's stored in the cells. It's what we call metabolic inflexibility because we have this insulin resistance piece. And so when insulin is up, our body is driven to consume fuel. And the fastest way to raise that glucose is by eating sugar or simple carbohydrates. So when we put people on a sugar fast, it is hard. I mean, I will tell you, it's really hard, but we remove all those simple carbohydrates as well to really fix that metabolic flexibility piece first so that the body can access the stored fuel. So when the glucose starts to lower, the body can pull the stored fuel out of the cells and it doesn't have that drive to raise glucose externally. It can raise it internally. It's fairly complicated to explain, but it's when we don't have metabolic flexibility and we can't access our stored fuel, the brain is going to be driven to consume fuel, and the fastest fuel it knows is simple carbohydrates and sugar. And so it's a complicated thing. And then realize, I mean, the addiction is there. For a lot of us, it is there. I mean, when I eat sugar again, it lights up my brain like a Christmas tree. And I go, well, I could get more of that. And I start bargaining. And I mean, it really, it's powerful. And so recognizing that this is powerful, this is how we work on it. And it's a strategy. It's not a quick fix, but it involves really fixing the biochemistry.
Very good. Next question comes from Karen. Can you explain what causes the dizziness with GLP-1s?
It probably, I mean, dizziness is so hard because dizziness can be so many things. In medicine, the word dizziness means so many things. I mean, hopefully it isn't vertigo, because vertigo is its own problem in the inner ear. I think a lot of people mean lightheadedness. Hopefully that's what you mean. And lightheadedness can often come from the struggle to pull the fuel out of the cells. So to raise that blood glucose level when you don't have metabolic flexibility. And so the blood glucose is actually getting kind of low because you haven't brought in enough fuel by eating. So a lot of people use GLP-1s just to drop the hunger. But if we haven't fixed the problem, then lowering the hunger really is going to manifest in other ways. So we're going to lower our metabolic rate if we can't bring in enough fuel. A lot of it can be dehydration. I mean, a lot of people aren't drinking enough water. I mean, most of us are so physically accustomed to dehydration that we don't even recognize it as a problem. So I would say working on dehydration, working on sleep, because if we're tired, we're going to feel woozy. We're often used to compensating fatigue or energy by bursting with sugar and bursting with simple carbohydrates. So our solution to fatigue is to blast the body with blood glucose. And when we stop doing that on a GLP-1, we don't have other coping mechanisms physically. And so we really struggle. I think, again, putting it in context of the whole, like, what are we treating? If we're just treating food intake without treating the underlying problem, we often create more problems for ourselves than we solve.
Next question comes from Karen again. Can you discuss the concept of microdosing these medications?
I don't know that I can discuss that because we don't do that. I mean, way back in the olden days before Ozempic was approved as Wegovy for treatment of excess weight, we played around with dosing Ozempic daily to mimic Saxenda when that's all we could get. And so we gave it And it was very off label, but it was really trying to say, how do we do this, with other medications? But we don't do that. I think it has a very long half-life. So if you can get it into the body, it's going to stay active for a while.
Okay. Very good. What is the prospect for use for type 1s for blood sugar management? What is the prospect for use, I guess, for the use of the medications?
For the use of the medications, I mean, we have used it in patients with type 1 with very strict guardrails because it's a very, very different scenario. I mean, with type 1, we're not making insulin. But what can happen with type 1 is you can develop insulin resistance. So then you have essentially type 2 layered on top of type 1, which is very complicated. I would say never do that without somebody, either an obesity medicine specialist or an endocrinologist that's very familiar with the physiologic processes that are happening, because you don't want to fix one problem and create another one. I would say there's definitely potential in somebody with type 1 who also has insulin resistance, but proceed with lots of caution.
Very good. Okay, the last question comes from an anonymous attendee. What do you think of the effectiveness of digital lifestyle interventions in managing type 2 diabetes, and what are the health outcomes beyond HbA1c that you would be interested for? And what about type 2 patients on insulin in this approach?
That's a loaded question. That's a big question. I think we have to come up with digital interventions to deploy a lifestyle intervention. But I think the problem with most digital interventions is they are centered around the idea of getting people to eat less and sucking up the misery of eating less. And I think we've proven over 50 years that doesn't work. So why we keep trying it is beyond me. I think a digital lifestyle intervention needs to focus on the insulin resistance piece, to work on the things driving the insulin resistance piece. And then it has to be supported with human interaction, because it's really hard to just fix your sleep because somebody told you to. It's hard to fix simple carbohydrate addiction because somebody told you should. There's really there's an element of coaching and mental health that really has to be addressed at the same time. And I think trying to do one in a silo is very ineffective. So I think it has to be a combination approach. So I think when somebody, I've been trying to come up with that. I am not a digital person. I don't understand tech that well. I've been trying to come up with that, but it's so difficult in this world of digital interventions, and don't even get me started. But there's so much that needs to be deployed correctly, and I think it's going to take a village. So I think that needs to happen. And then the other part was what? Remind me. I got stuck on that piece.
It was hang on, I gotta pull up the question.
Something about people on insulin.
Yeah, it's and what about type 2 patients on insulin and this approach? So
I mean, a good obesity medicine doctor, we typically say, let's get off the insulin, right? Like that's one of the first goals. It's really hard to fix insulin resistance when you have to inject yourself with insulin all the time, but there is a way to do it safely and cautiously, but it is nuanced. That is definitely something that takes somebody with a lot of experience in that field, because you do need insulin. Yeah, I would say that's a one-on-one conversation that's deep.
okay.
And not quick and not easy. And
okay.
Precision medicine comes in there of like, it's not a one size fits all either. That's not something that can be built into an AI algorithm.
Okay, the next question, thank you. The next question comes from JD. How do we find an obesity provider? I have a PCP, PA, and a nutritionist, and both have mentioned medications, switching from metformin, but they don't have the info that you have shared today, or they don't share it.
Yeah, I mean, I think it's really hard. And not all obesity medicine providers are really schooled in the thought of fixed metabolic health. A lot are just focused on eat less, let's make it easier to eat less. So I think we're not very unified yet, and that's sad, but I think we will get there. Looking for obesity medicine providers, you can go to the American Board of Obesity Medicine lists all of the people with a board certification in this field. And I think that's a good starting point. There's, I think, 5,000 or 6,000 of us maybe. And then the Obesity Medicine Association lists those of us that are really involved in the process of trying to teach and be involved in the world of obesity medicine. And then I think you have to find those people in your area and then check out their website, because some are just in academics, which is wonderful. We need those people doing studies and working on those kinds of things, or seeing 5 patients and studying them fully. Like there's wonderful people doing that work, but those aren't really working on that. And then make sure we're not attached to a med spa that's really their goal is to just make you beautiful, which again, there's a place for those people too, but like that's not this, there's a percentage of us that are really working on metabolic health. And so start reading what they're saying and how do they approach treatment. If they're just approaching it to eat less, then that's a different story than what I'm talking about here. I don't think there's a heading for us. It's not lifestyle medicine. It's probably going to be a field called metabolic medicine or mitochondrial medicine or something as it evolves. But I think you have to do some research and find that. And it's not easy yet.
The last comment was Sharon, she said day 2 had a digital component. So it was a digital intervention, right? That was based on her gut microbiome and predicted her glucose response to what she ate. And she used their app with coaching and lost 18 pounds. And she said the approach helped her to decrease her appetite. So it was, I think, it's just a comment saying that there are things out there that work. And thank you Sharon, for the comment.
Yeah, I think the gut microbiome is huge. I mean, I think
a lot of studies.
I mean, I think we have 3 pounds of bacteria living in there and they make hormones. I mean, why are we ignoring these things? Right. And what we eat has a huge impact on the microbiome. So yes, you can take pills, but if you don't set the stage up for them to grow, then they're not taking root. And so I think there's a lot of that we approach in our treatment process with patients is we really focus on our gut microbiome and putting the right things in there and not killing off the good stuff.
Exactly. Last question we have time for, and it's what is your suggestion for the person that doesn't have access to an obesity doctor, a high protein diet?
So the foundation of what we do. So if you want the nuts and bolts of how we teach that, just the nutrition piece, right? I can't even get into the rest, but the nutrition piece is we do adequate protein and it comes from whole foods. So not protein powders because they're full of artificial sweeteners, which then destroy the gut microbiome. So plenty of dietary protein. And average is, ideal is probably 1 milligram per kilogram or 1 milligram per pound of ideal body weight. I know enough for people, I want you to weigh 120 pounds, but like if you sit back and say my ideal body weight is somewhere between 105 and 122 pounds, I'm never going to weigh that. But like, that means I need 105 to 122 grams of protein a day. Okay. And get that from foods that aren't full of sweeteners, that aren't powdered. Definitely get plenty of fiber to feed the gut microbiome. So we do, plenty of protein, plenty of fiber in the form of vegetables. It doesn't come in pills. Like you have to have the insoluble fiber that comes in vegetables and you feed the microbiome, and then get rid of the things that stimulate the blood sugar. So we just say, lower the insulin, feed the gut, protect the liver is kind of what we come down to is so lots and lots of whole foods. Douse that food in olive oil and put some cheese on top of it and eat it. But, don't introduce the things that raise the insulin. It's almost hard to just put into a quick, but whole foods. Getting rid of ultra processed foods really solves almost all 3 of those problems. Now you can put back in, sugar, although it's fairly processed. You can put back in some things that'll undo it. But it's
Okay. All right.
Protein, fiber, whole
exactly. Right. So we're just about out of time. I know we went over, but thank you all for your questions. And Dr. Younglove, thank you for your insightful and impactful presentation. Dr. Younglove has a tip sheet. It's available at our website now for download. So go ahead to our website and you could download that. So a big thank you to Dr. Younglove and to Eli Lilly for their ongoing support and sponsorship of Diabetes Sisters. And thank you all for joining today. I know it was a great presentation we went over, but very well worth listening to. So thank you again. We look forward to seeing all of you at our next webinar.